I'll go ahead and introduce our next speaker, who's Dr. Len Gomella, who's the chairman of urology at Jefferson University.
Thank you. Good morning, everybody. I want to thank the AUA, the SUO, and certainly the AUA Office of Education team for now sponsoring this course for the last 8 years. It's really been a tremendous boon, I think, to all urology. So I have the pleasure of talking about a relatively dense subject for most urologists, and that's this entire area of genetic testing, which is something which has come on fairly rapidly in the practice of urology. These are the general areas that we're going to talk about: screening, surveillance, treatment strategies, prostate biopsy, confirmation, and precision medicine. So there are many different aspects of genetic testing that can be utilized in the management of all stages of prostate cancer, from screening all the way through the management of refractory metastatic castrate-resistant cancer. So I always like to show this slide because this whole field of genetic precision medicine, genomic testing, is fairly new in all of medicine. And it was really through the Human Genome Project that took many years to complete. Get our wires fixed here. Go back here. So it took 13 years for this project to be completed. And actually, as we'll see in a minute, the project really wasn't completed in 2003. It took about another 10 to 12 years before it was completed. But this opened up the entire world of genetic and genomic testing in the field of medicine, and certainly with its major impact in prostate cancer. So something very interesting happened in 2013. Angelina Jolie presented to the world the concept that you can inherit cancer from your parents. And this was a brand new concept, and I think it was very important because she talked about her BRCA2, her BRCA hereditary breast and ovarian cancer. The same year, the Supreme Court came out and basically said that DNA could not be patented, whether it was naturally occurring or mutated. Why is this 2013 important? Because all of a sudden, over the last 11 years, there's been a major explosion in a large number of companies that have gotten involved with genetic and genomic testing. And certainly, as you go through the display here, you can see many companies that have benefited from the Supreme Court decision bringing genetic and genomic testing into the field of prostate cancer. It was finally in 2022 where that last little bit of the human genome was finally unraveled. But here's the interesting thing. There's all this dark DNA out there. In fact, the majority of our DNA, we have no idea why it's there. And I think it's going to be many, many, many years of unraveling. Why is all this genetic material out there and we don't know actually what it does? So we really only know very little about the active genetic agents in our human genome. So to go back again, how quickly this has come about, before 2016, if you wanted to know anything about prostate cancer and BRCA2, you had to look in the hereditary breast and ovarian cancer guidelines. They were not anywhere in urology. Finally, in 2016, there was the first mention of this using the NCCN guidelines as a guide point for exactly how genetic and genomic testing has evolved in prostate cancer. Finally, in 2017, there was the first mention of family and hereditary genetic considerations for screening. By 2017, the treatment guidelines talked about PARP and DNA. 2018, there was consideration for germline testing, and by 2020, it was embedded that is recommended for patients with advanced prostate cancer that genetic testing be done. So we got involved with this at Jefferson and the Kimmel Cancer Center, and many of the faculty on this program today were involved, where we got together an eclectic group of individuals from all around the world, gynecologists, medical oncologists, ethicists, and brought forward a team approach to how do we actually do genetic testing for inherited prostate cancer risk. And a lot of that has now been embedded in many of the guidelines. So this is a fairly new topic in the field of urology. So next, what I want to do is just touch on some of the basic concepts in genomic and genetic testing. So We could not do this if it was not for computers. It's impossible for any human being to sit down and go through all of the different ATGC gene combinations. Here's an example of a normal BRCA2 gene, 27 exons long, 12 pages long. This is just one small part of exon 11. So you might imagine that if it was not for the benefit of computers, we could not do any of this genetic analysis. Now, I want to make an important point. When we talk in the remainder and probably most of the day today, when we mention a gene like BRCA1 or BRCA2, we are referring to the mutated gene, not the naturally occurring gene. And what you all have to realize is that there is not one mutated BRCA1 or BRCA2 gene as the big example. There are literally hundreds and hundreds of them. And these all go into a gene bank, which is run by the National Cancer Institute and the National Institutes of Health. And you got to be careful about online gene testing, because sometimes they're only testing for a very limited number of genes. So when patients go out and get one of these, I call them recreational genetic tests, you got to be careful. They may not be getting the entire look at all of potentially reported mutated genes that are out there. So here's an example of a report that came back from one company identifying a pathogenic mutation, but look at the incredible detail this goes through. It identifies very specific deletions in a very specific port. So this is not very simple, and that's why I'm a big believer in working with genetic counselors to help us guide through genetic testing for patients who may have different stages of prostate cancer. So again, mutated genes are not simple, they're very common. So when we talk about this, this is one of these take-home message slides. If you can remember this slide, there is inherited germline mutations that you get from your parents, and there are somatic mutations that I call the Wild West of the cancer. These are mutations that can pop up in the tumor itself that have no genetic component to it. And as we go through the day today, you're going to understand there's a role for both genetic and for somatic inherited testing and for somatic testing. To put a little more clarity on what we talk about, when we talk about genetic and genomic testing, it goes into three buckets. One is genomic profiling. These are proprietary RNA signals from companies that we're all familiar with, like Decipher, Polaris, OnType, and others, that are proprietary mRNA signatures. They're not necessarily mutated genes. They help us with treatment and decision making. We then have genomic tumor sequencing, which we'll spend a lot more time about the rest of the day, where you actually identify in the tumor itself a specific genetic alteration that can be targeted. Lastly, there's the concept of inherited cancer risk testing, which is normally done with just the buccal swab when you're looking for germline. You don't need a tumor when you're doing inherited cancer risk. You can just simply do this off of a buccal swab. So with that background, let's talk about prostate cancer and the risk of inheritance. At the end of the day, most prostate cancers are still sporadic. You have a sense that some of them may be familial. You may have a relative here or there that might have breast cancer or prostate cancer. But truly inherited prostate cancer, where you can clearly identify this germline mutation going through family, is probably somewhere around 10% of the cases of prostate cancer. So the majority of men have sporadic disease or familial disease. A very small subset do have actual, where a genetic counselor can identify where the germline mutation has gone through generation after generation. So recognizing that about 10 to 15% of patients who have prostate cancer have a hereditary component. The most common genes that we see in prostate cancer are BRCA1 and BRCA2, again, mutated genes. We have to remember another basic concept. These do not cause prostate cancer, but they increase the risk of developing aggressive cancer. But they also increase the risk of other cancers, and this is where we have to open up our eyes a little bit about urologists. No longer when you're in the clinic and you say anybody in your family have prostate cancer, you really got to do a deeper dive on potentially other related cancers such as hereditary breast, ovarian, pancreatic cancer, melanoma, Lynch syndrome, and the like. So genomic and germline testing are very important, mainly, as we're going to talk about today, to identify actionable genes such as pembrolizumab and the PARP inhibitors, which if they identify certain genetic alterations in the tumor, you can use these therapies to treat your patient. And then you also have to look at genetic and genomic testing when it came to screening for cancers, not only individual, but within their family. These are the common genes, the most common genes in metastatic castrate-resistant prostate cancer. You'll see that most of them are in the DNA repair pathway. We'll finish up the talk talking about that, addressing that a little bit further. The HOXB13 gene is a very unique androgen repressor gene that occurs in families where many men under the age of 50 to 55 develop aggressive prostate cancer. This is a very, very small segment, but one of the genes that should be screened for, particularly if there's a very strong indication of a family history. So this was one of the most critical papers that we've had come out in our field in many years. This is identifying germline mutations. These are inherited mutations in men who develop metastatic castrate-resistant prostate cancer. You can see there's a whole family of them. BRCA2, BRCA1, CHEK2, and ATM are the big ones, but there can be many, many other germline mutations that can be targeted in our treatment. And the more we do research, the original study said it was about 5 to 10%. Later studies show it could be as much as 20 to 25%. Now, this is where things get a little bit terminology crazy in our world of urology, and we'll spend some time talking about this. Most of the genes that we're talking about that contribute to the development of metastatic, they don't cause metastatic aggressive castrate-resistant prostate cancer. They don't cause it, but they seem to be involved somewhere in the pathway when it comes to developing these more aggressive types of cancers. So most of these are what's known as homologous recombinant repair response. In other words, we'll talk about this where the DNA maintains its integrity, and with one of these genes becomes mutated, the DNA is really unable to maintain its integrity. If you've got one of these germline mutations in the DNA damage response pathway, it tends to be aggressive. These are the men that tend to die from prostate cancer, develop aggressive metastatic castrate-resistant disease. And it also increases the risk not only of the man of other cancers, but members of their family if they have the same inherited germline mutation. And here's a very, very classic paper. This, if you look at the x-axis, this goes out 20 to 25 years. Men with germline mutations in ATM, BRCA1, BRCA2, even if they have localized prostate cancer at the time of diagnosis, are more likely to die from prostate cancer. So we have a signal here that these men, when we identify them, really need to be monitored more closely and potentially have more aggressive treatment. Next, we're going to talk about some of the practical considerations of genetic testing, NCCN guidelines, germline mutation. This is for patients where you're looking at their germline, strong family history of breast and ovarian cancer, multiple prior cancers, male breast cancer. Let's remember that we're related to male breast cancer very often with these BRCA1 and BRCA2 mutated genes. Genetic Ashkenazi Jews, and the reason the Ashkenazi population is mentioned, they are the founder population. This goes back to the mid-1990s, where the companies identified in the Ashkenazi Jewish population the BRCA2 and BRCA1 genes that really broke through the entire study of inherited cancers such as breast and ovarian cancer. So we have a lot of companies out there that are in this business. The companies all generally have similar gene panels, but they may be slightly different. These are some of the prostate cancer specific gene panels. However, there are other panels out there to do for germline testing that look at many cancers, not just prostate cancer. If you get into the area of companion diagnostics, and those we're going to be talking about a lot with things like olaparib and rucaparib, there are several companies out there that have FDA-approved germline and somatic testing as companion diagnostics for prescribing their medications such as PARP inhibitors. When you do genetic testing, and you look for germline mutations, they may be pathogenic or they may be something known as a VUS, or a variant of unknown significance. What does that mean? If you send a patient for germline testing and the VUS comes back, that means there's a gene that's out there that hasn't been classified yet. And again, this is why I think we really need to work with our genetic counselors who will follow this patient to the point where the VUS either is described as a benign mutation or as a non-pathogenic mutation. Again, this is what I think, as a urologist, I get a little bit nervous about, because if I order the germline testing and a VUS comes back, I'm sort of obligated to follow that patient over the long term. So somatic tumor testing now moved to actually testing the tumor. Tissue biopsy is the most common technique, but liquid biopsy, looking for cell-free DNA, is coming on very strong to look at factors out in the blood that may be related to the primary tumor. This is an example of a somatic test that you would get back. Now, this is a somatic test that shows over 300 potentially mutated genes. These are important not only for research, but may indicate drugs either on clinical trials or that are available to treat this man. It also identifies tumor mutational burden and microsatellite instability that are important for certain medications such as pembrolizumab that we'll talk about later. So the bottom line is somatic tumor testing identifies actionable mutations, mutated genes where we now have specific agents for that man to go ahead and treat him who has advanced and usually metastatic castrate-resistant prostate cancer. Liquid biopsies are really coming on strong. We're not using them a lot in urology, but certainly medical oncology has really embraced this, looking for cell-free DNA factors circulating in the blood to avoid doing an invasive biopsy on a patient who may have metastatic castrate-resistant prostate cancer. We have a bunch of commercial assays out there, and again, I know there's many manufacturers here today that look at both tissue analysis and liquid biopsy assays. And again, if you're going to get involved with treating patients with metastatic castrate-resistant prostate cancer as a urologist, you really need to do a deep dive and understand the tissue assays and the liquid biopsy assays that are out there. So what's the advantage of direct tumor testing? It can be done under archived tissue or new fresh tissue that you get from a biopsy, and usually there's a lot of material for genomic testing. However, invasive testing in a man with let's say, a bone lesion or difficult to access lymph node may be challenging. And again, sometimes you may not hit the proper part of the tumor. There may be tumor heterogeneity and that metastasis that may not be direct related to the rest of the metastatic lesions. Liquid biopsy allows for circulating DNA in the samples. It's minimally invasive, not hindered by limitations in tumor access. However, sometimes if a patient's recently started a new treatment, such as androgen deprivation, the cell-free DNA component out in the blood may be altered. And again, the cell-free circulating blood test can't distinguish between somatic and germline mutations. So if you're going to be identifying a man who has one of these recombinant DNA repair gene pathways, fresh metastatic tumor biopsy is always the most important. Circulating tumor DNA, if you can get it, is important. Archival tissue can be used. And lastly, the only thing that you really can do with blood or saliva is really saliva is germline testing. You can do blood testing now for circulating factors. Lastly, this all collapses into the area of precision medicine for advanced prostate cancer. And this is a slide that many of you are probably very, very familiar with, where you look at the whole spectrum of prostate cancer. But as you move to the right-hand side of the slide, this is where precision medicine comes in. We have genetic tests now for these 5 or 6 agents that we'll talk a little bit more about. We have tumor mutational burden and microsatellite instability for agents such as pembrolizumab. And let's also remember that with PSA imaging, that's now precision medicine. That tells us this man may be a candidate for lutetium-177. So this is sort of a word salad that urologists need to become familiar with: DNA repair genes, homologous recombinant response genes, an HRD tumor. When you read through papers, you need to sort of understand this word salad a little bit. What's an HRD tumor? It's a tumor that you've identified one of these DNA repair pathway genes in. So again, we have to be very familiar with this lingo, particularly if you're interested in getting involved with treating patients with advanced metastatic castrate-resistant prostate cancer. You really need to understand what the papers and what the different medications are referring to. But at the end of the day, the homologous recombination response pathway is become critical in the development of many of our new agents that we'll talk about today. The first two were rocaparib and olaparib. And again, when these genes are mutated, what happens is these drugs become primary agents to treat patients. Most patients that don't have these mutated pathways tend not to respond that well to rocaparib or PARP inhibitors in general. They can, but the targeted patient is the one who has a homologous recombination response, mutated gene, and we have that whole family of genes that we've talked about. These are the different DNA repair estimates in advanced prostate cancer. Looking at both germline and somatic is generally recommended as the best approach. That's not to say that you might miss a germline mutation in the main tumor. Sometimes you can. It can be overwhelmed. But again, if you're going to be serious about this, they are additive, and it's probably a good idea when you're dealing with metastatic castrate-resistant prostate cancer. If you don't have a germline sample in the bank, you probably should, but if you don't, you should do germline and somatic testing on those patients. And again, this guides treatment today. This is very important. And again, the poly-ADP ribose polymerase enzymes, or the PARP enzymes, are very important, and that's why we use PARP inhibitors. And why is that? This is something known as synthetic lethality. It's kind of a confusing concept, and you really have to follow it through. But normally, as we've talked about, genes like BRCA2 and BRCA1 maintain the DNA stability. They keep the DNA intact, making sure it does not have a lot of mutations. When that gene is mutated, what happens is PARP comes in and salvages that cell. It keeps the DNA intact and allows the cell to continue growing. So what we do is we throw a curveball at that PARP inhibitor. So if you've got a mutated BRCA2 gene, PARP comes in as the rescue to keep that malignant cell from growing. But now if you inhibit PARP, you've really limited the ability of that mutated cell to continue growing and have a high likelihood of killing the cancer. The two drugs that we have, as we mentioned, olaparib and rocaparib, we'll do a lot of talk about those drugs today, but again, they depend on identifying BRCA1 and BRCA2 and other HRR pathway mutations. The guidelines, again, if you go through this, we have a lot of recommendations now in the new guidelines that will be discussed a lot at this meeting, has already been presented, looking at PARP inhibitors, looking at which patients with which conditions do you get germline testing or you do somatic testing. Again, we will talk about a lot of these drugs. We'll talk about a lot of these important clinical trials as the day goes on, but you can see here that you have this ongoing thematic indication of mutated homologous recombinant repair genes over and over again that interfere with the PARP enzyme coming in and keeping that malignant cell from growing. And again, this is a very, very important area for us. This has been one of our advances that we've made in prostate cancer over the last few years. And again, this all ties back to the Human Genome Project and understanding the basic science of the mutated genes and how they are operational in prostate cancer. So in conclusion, we have very rapidly evolving recommendations for the management of prostate cancer across all stages, from screening through the most advanced cases of metastatic castrate-resistant disease. All patients with metastatic or aggressive forms of cancer really should have genetic and genomic testing. Again, Those are our top genes today: BRCA1, 2, HOX, ATM, and CHEK2. Certainly, the list goes on and on. These are just the big, most common ones that we talk about, and the ones that you will see that are reported in most of the clinical trials, such as the Magnitude trial and others. And again, remember, when you have a patient with metastatic disease or a suggestive family history, you should, at a baseline, before they even develop castrate-resistant disease, get a germline test in the bank on that patient. And again, growing role for not only somatic tumor biopsies, but for cell-free DNA in the circulation to help you guide treatment for men with advanced disease. And lastly, again, I'm a big believer in working with genetic counselors and helping us not only to understand what's best for that patient, but also what must be useful for their family. That's called cascade testing. And I think that's an important concept. Again, most of our commercial companies will partner with us and actually help us with some limited levels of online counseling. But again, I think if you're really going to be in a center where you're treating a lot of advanced prostate cancer, you need to have your dedicated genetic counselors. Again, thank you very much for your attention.